So much for coming to the first Implementation Science for Maternal Health adjunct session to the D&I conference. We are really thankful that you are all interested enough to be here with us today to discuss what we think is a really important topic. So just to briefly review our schedule, first we're going to go over where have we been, kind of the emergence of implementation science and its intersection with maternal health. We'll move on to where are we now. We have an exciting panel discussion with some panelists who are working really hard at this intersection. Then who's on this path? We'll split up into small group networking sessions so that we can all sort of meet each other, collaborate, find ways that we can continue this interest moving forward and help to improve things. And finally, we'll end with where are we going? We will actually talk about a project to set formal implementation research priorities at the intersection of maternal health and talk about a little bit about what we want to do with the future of this group. So just a little bit about us. My name is Rebecca Hamm. I am a new assistant professor in maternal fetal medicine at the University of Pennsylvania. And I did my MSc here at Penn as well, where I trained with Renad Betis and Megan Lane Fall, who have been fantastic implementation science mentors to me. And my work kind of centers in implementation science on labor and delivery as a means of improving disparities in care.
Hi, and I'm Jennifer Callaghan-Koru. I'm an assistant professor of public health at the University of Maryland, Baltimore County, and my research relates to using behavioral science and implementation science to improve outcomes and quality of care for maternal health.
And Jennifer and I met at the last D&I conference last year and realized that there were many of us who had these same interests and worked to put this together. We originally imagined this as an in-person meeting over some cocktails at the D&I conference, but this is kind of the alternative to that, and we hope that you find it worthwhile. So where have we been? The emergence of implementation science and its intersection with maternal health. For most of you on this call, this is not something that you need to hear again, but maternal morbidity and mortality is a significant issue worldwide and a significant issue locally in the US. There are complications that occur antepartum, during delivery, postpartum, many of which are preventable. And there are significant unacceptable disparities by race, socioeconomic status, and ethnicity in these birth outcomes, particularly within the US. And we do have evidence. Our field has taken these enormous strides to produce evidence, write comprehensive bundles that are aimed at improving outcomes, anywhere from SMFM patient safety checklists to the Council for Patient Safety and Women's Health bundles like the Maternal Mental Health Bundle and OB Hemorrhage Bundle, the WHO recommendations like the Intrapartum Care for a Positive Childbirth Experience. And yet we haven't really learned to successfully enact these evidence-based practices more broadly. I'll use some of the implementation science terminology throughout this talk that might be a little bit newer to some of you who are not as familiar with the field. They usually say EBP, evidence-based practice. So why implementation science? Data across medicine demonstrates that only about 50% of evidence actually ever gets into routine care, and that the gap from publication to incorporation to practice can be as much as 17 years. And current medical science focuses really hard on the breakthroughs without any appropriate emphasis on follow-through and sustainability. And in order to optimize patient care, we need to decrease that evidence to practice divide. Yet this is difficult, right? Healthcare implementation is really complex. Oftentimes, clinicians may not be aware of the most current research. Organizations and providers might not have the tools they need to implement these interventions. And sometimes interventions, while they work in a research setting, aren't actually aligned with the patients and communities they're supposed to be for, or might not be as effective in a real-world context. Also, there are many things that impact whether an intervention succeeds: the physical environment, the socioeconomic and cultural context, the characteristics of the health system or the person who's using it, all play a giant role in the success of an implementation. And it's really not surprising that evidence-based practices that we think could actually improve maternal morbidity and mortality haven't actually made their way into widespread use. So what does implementation science do? It actually aims to bridge the divide between the development of evidence-based interventions and their use in the real world. And so this emerging field takes into account stakeholders at the clinician, institution, health policy levels, and evaluates how well an intervention is or can be delivered, to who, in what context, and how we might scale it up and sustain it. This subway map of implementation science was created by Renad and Megan, two of my mentors, and it kind of gives you an idea how to think about implementation science in the context of other research. So first, research is often about efficacy. Does an evidence-based practice work in a controlled research setting? And that's that red area up top. And once you've proved that, you move on to effectiveness, this yellow area on the subway map. Does the evidence-based practice actually work when you put it into the real world? And then this green area is the work of implementation science. How do we actually get people to use this evidence-based practice? And so, these types of studies include hybrid effectiveness implementation trials, mixed method studies to understand context, how to design implementation strategies and then test them. Other fields have already done a great job of kind of implementing implementation science into what they're doing, particularly within the cancer world and the aging world. And we are starting to do this too in maternal health. This chart shows publications of a PubMed search that we did, and Anaya, Jennifer's research assistant, did amazing work on, looking at the number of publications by year in maternal health and implementation science. And you can see that it is increasing significantly in the last 5 to 10 years. This is just a sampling of grants that we found on implementation science and maternal health. And further, this is a list of the presentations at the D&I conference over the last 3 years, and just a sampling of some of the titles of those presentations that related to implementation science and maternal health. Here is a smattering of the presentations this week, and you can see that they are, again, increasing in number, and really exciting work at this intersection of maternal health and implementation science. We hope that you'll go and visit these posters and orals throughout the course of the next few days. And where we hope that this will go. So we hope that this will inspire further work at the intersection of implementation science and maternal health, that this group will help inspire collaborations among us, that we can create a community within which we can continue to develop and advance ideas with the goal of improving maternal health. And then, like I mentioned, sort of begin to set these formal research priorities in this arena. So now we'll move on to our panel discussion. And our panelists, due to a kind of a mess up in our recording earlier, we do not have the recording of the panelists introducing themselves, and so we are going to just read some brief bios of our panelists.
We have 4 panelists today who are people who are working at the intersection of implementation science, implementation research, and maternal health. First, we have Dr. Debra Bingham, who has developed and led several state and national quality improvement initiatives that have reduced maternal mortality and morbidity. She's an associate professor of healthcare quality and safety at the University of Maryland School of Nursing, where she's expanding the utilization of implementation science and improvement science theories, frameworks, models, and QI methods tools within the Doctor of Nursing Practice curriculum. We next have Dr. Claudia Hanson, who's an associate professor in epidemiology and maternal health at the Karolinska Institute in Sweden, as well as the London School of Hygiene and Tropical Medicine. Dr. Hanson is trained as a medical doctor with a specialization in obstetrics and gynecology, and has been working for many years in Tanzania and other countries on improving maternal and reproductive health care. She has led the Karolinska Institute Implementation and Quality Group that aims to generate knowledge to develop, implement, and evaluate strategies to improve the quality of care. Third, we have Dr. Hisrchhorn, who is a professor of medical social science and psychiatry and behavioral science at Northwestern University Feinberg School of Medicine, and is also senior director of implementation and improvement science at Last Mile Health. She's trained in medicine and HIV and is an expert in implementation research and improvement science, actively applying these methods to improve the quality and equity of care in resource-limited settings, including maternal and child health, HIV, primary care, and non-communicable disease. And fourth, we have Dr. Michelle Moniz, who is an assistant professor in the Department of Obstetrics and Gynecology and the Institute for Healthcare Policy and Innovation at the University of Michigan. Dr. Moniz has a busy generalist obstetrics and gynecology practice at Northville Health Center. And she is also part of the program on women's healthcare effectiveness research, which is a collaboration of health services researchers focused on improving value and outcomes in reproductive health care. And now we'll transition into the comments and insights from our panel. So I'm going to jump ahead to a question that we wanted to ask each of you to think and help give us some ideas about how, as interested parties, all of us on this call, we might work to advance the field of implementation science and maternal health. I'm thinking about things like implementation frameworks and whether they're working well with maternal health, whether they need any adaptation, and what you see as the most important areas of work for implementation science related to maternal health.
Do you want me to go first, or do you want to go in order, or how do you want to do that? Is that right? Or
is it easier if we prompt you?
yeah, either way, like if you have, so you want, I guess, all of us to answer that question. So yes, so is that right, Jennifer?
If you have ideas on it, please answer, and maybe we can do alphabetical order so that it takes away any uncertainty.
Forwards and then backwards. Yeah.
Yeah, forwards and backwards. That sounds great. Yeah, no, it's, to me as a clinician, I think of implementation science as the physiology behind QI. I think if you try to, so like other clinicians, I looked at the list and others would probably relate to that analogy. So if you try to, you can learn how to take a blood pressure, but if you don't understand the physiology, you don't know how to really take that information and use that information in an effective way. And so without the frameworks, without the science of implementation, then as an implementer, I'm unable to make as, the choices I make are not going to be as effective. My implementation efforts will not be as effective. At the University of Maryland, I help guide the implementation projects for approximately 125 students that are graduating each year with the doctorate in doctorate in DNP, nurse practitioner doctorate. Anyway, they become a nurse practitioner, advanced nurse, and they're in all areas of healthcare. And University of Maryland is ranked one of the top 10 schools in the United States. And when I joined the faculty, there was very little that, in fact, I did a survey of the faculty. Almost none of them knew QI tools and methods. None of them knew anything really about implementation frameworks, yet it's one of the essentials for these graduates is that they have some implementation expertise. And so I've been working on expanding the capacity and expertise around implementation science, principles, tools, quality improvement methods and tools at the University of Maryland, which has now expanded to connect with other schools across the country who are also graduating DNP graduates. We formed expert panels, and we also right now have just formed an expert panel around what we call the racial equity, justice, implementation strategies panel. These, they're not going to go out and do implementation research after they graduate. What I'm helping them become is utilizing the research and having evidence-based strategies and tactics for implementing. The Regis panel we just put together around racial equity and justice implementation strategies panel is looking at the ERIC work, the expert panel that put together a list of strategies, which I then reorganized because the implementers were struggling with all of it's a fire hose of information and just trying to make it as practical as possible for them. And be able to, because they're also studying to become a nurse practitioner, right? So, but we want that, so that tension between being a good clinician, being the expert clinician, a doctorate, that you also become that you use implementation scholarship is what I'm working on. But none of these implementation strategies included the word race or racism or disparities. And I was like, oh my gosh, as I put together this handout where I organized these for them to pick from, what strategies and tactics are you going to use in implementation? I realized we had like huge gaps in also our language as implementers. And so Byron Powell, who is the lead author of the paper on that, did join the panel, and I have several other people who are leading efforts nationally on the panel to help advise the work. And then the last thing I'll add is then right now, also for a couple of years now, a few years ago, I launched the Institute for Perinatal Quality Improvement, and that is specifically focused on people who, health professionals who've already graduated, who are already out in the field. So I'm working both upstream and then the people who already graduated in the stream, and helping improve their implementation effectiveness. And that's specifically focused on eliminating preventable perinatal deaths and injuries and eliminating perinatal disparities, which, by the way, I know we can eliminate because we've done that successfully in other areas. Most of these disparities, if not all, are completely preventable. So anyway, that's a little bit of how I'm kind of bringing it together in my spaces.
If we do forwards alphabetical order this time, then Claudia, you would be next.
Yes, very good. So my thinking comes also a little bit of from design thinking. So when I go actually in a delivery ward, I think how people work. And when the first time really started to get interested, I was in very rural areas trying to scale up treatment for sexual transmitted diseases, including also eye ointment for the neonates. And then I asked them, do you have your eye ointment here? Is it regularly available? Everybody was saying yes. And then I asked them, where is it? And then it was typically locked in a pharmacy with a key. And I asked them, so how are you going to get this eye ointment at night if you have a delivery? Yeah, and it was completely clear that they never used the eye ointment. Yeah, so, and then I tried really to talk through with them. So can you maybe put it in a drawer? Okay, you take only one, and then you exchange it the next day, just trying to talk them through how they can actually do the improvement, that it's actually really there. Yeah, and then also on other level, we have just evaluated a quality improvement project in India. And there the question was, it was implemented by an NGO, a typical public health NGO, and with a limited budget, and they had to go and do quality improvement in tertiary hospitals. So public health people with mostly nurses went to a doctor who had publications telling him about hand washing, which is a problem. So the question was, and it also became relatively clear that it was very difficult to implement because of this, that a tertiary hospital pediatrician was not likely to accept actually a quality improvement initiative from a nurse, even if it would have been fantastic to learn hand washing. Yeah, so we need to keep this in consideration also, who is actually trying to move things if we want to have successful quality improvement. And then nobody understood in this setting easily what's quality improvement, because quality improvement for 30 years have been clinical training. Yeah, so that was also a misunderstanding. So in that setting, it would have been easier to implement quality improvement together with clinical training, and probably to get it implemented also together with professional association. So that is then again a bit health system thinking. So who is the right person? How can things be implemented? And how can it really reach the people? So who is the right person actually saying we are all washing our hands?
Yeah, that makes sense.
So this is just a few thoughts.
So thanks, and sort of I think probably going to echo some of what's also been said. And I had to smile a little bit when you talked about the quality improvement in India, because I don't know if Catherine Semrau is on here, but worked with her on the Better Birth trial, which was, you know, really, can you do an RCT of a complex intervention? And one of the first things that we did was we actually had the exact opposite, which was in the pilot in Karnataka. It worked incredibly well. And when we did some pilot testing, which is again one of the key things that I think we learn from implementation research, as opposed to just diving in with a good idea, is that actually we had to adapt it, and nurses wouldn't take it from the doctors. We actually had nurses coaching nurses. So I think from my perspective, the reason why, implementation science holds, and it's really implementation research that we're talking about at this point. Implementation science is the development of the methodologies, the development of the frameworks, which are very important. There's well over 100. So I think it's how do we actually apply that to get the answers that we need to understand what's working and why, and what's not working and why not. And so a couple of thoughts on that. The first is that with over 100 frameworks, somebody said to me, and I've forgotten who to attribute this to, but frameworks are like toothbrushes. Everybody has one. Nobody wants to use somebody else's. So I think one of the important things is for us to figure out how do we sort of simplify and make this really more practical. So we talk about pragmatic trials. We need to think about pragmatic implementation research that actually retains enough rigor that we can actually create generalizable knowledge, which is the definition of research, but that is not so complex that it actually needs somebody to interpret and to have an expert, at the highest level, as opposed to building what I call embedded research, so that the person at the Ministry of Health, the person who's in the NGO, the person who's at the district or facility level is actually able to understand, to value, and to use this. And that has very important things for the D of the DNI, which we often don't pay as much attention to. I think it's also important because it brings in a discipline and a methodology to, in borrowing and some overlap with quality improvement, to understand the causes, identify the strategies and mechanisms about why they might work, and then how to integrate that in the practical world into effective monitoring and evaluation, so that, again, you don't do the big reveal at the end, did this work or didn't this, but the idea that you're, again, continuously adapting. I also think that, and this borrows a bit from patient-centered outcome research, which is sort of another area that I work in. So when we think about quality, not just technical quality, but experiential quality and patient-reported outcomes that they value, is that it really focuses on the perspective of the key stakeholders, not just at the beginning, but also throughout. And the one stakeholder I might add to the really great rapid overview we got was also the clients and the community. And to bring that in and to value that and to take the time that it takes to actually adapt before we implement, and then adapt as we are continuing to do it. So I think there's a lot of really effective tools. I think similar to many new disciplines, it's gotten very big quite quickly. And now I think it's to some extent the onus on the people who are the implementation researchers to figure out how do we make ourselves more nimble, so that, for example, if we think about implementation research within COVID, the perfect study that gives you the answer in 3 years is not going to be helpful. And so how do we figure out what is the discipline we could bring, what are the frameworks that are most effective to help us identify things and to begin to understand what are the underlying causes and what are the strategies, and as was just pointed out, how are the strategies being implemented, and how does that differ in, for example, in Chicago versus in Monrovia versus in areas that I work, which is last mile in Liberia, which are places that are 5, 10, 15 kilometers from the nearest facility. So it brings a way of us beginning to think about it. It brings in some common language, but we have to be very careful, I think, at this stage to make sure that it doesn't get so complicated that it becomes really unreachable and no longer pragmatic, no matter how pragmatic we want to make our trials. Thanks.
We've gotten, sorry, Dr. Moniz, before you go in, we've gotten a couple of questions in the chat that I think maybe you would be able to address a little bit in your response if you'd like, which are around the differences and similarities between implementation science and QI, which I think is one of the really common questions that those of us interested in this field get. And then sort of whether people have thought about or developed a presentation on implementation research in maternal health clinical contexts. And I think this relates to your work, but in sort of that overlay between implementation research and maternal health specifically, and where you think that relationship lies.
Sure, I will do my best to take a stab, and I invite and the other panelists to chime in as well. I think I'm probably the earliest in my career on this panel with the least wisdom, so I'll impart what I can and leave space for others to jump in as well. So I think about quality improvement and implementation science as really important kind of flip sides of a similar coin. Quality improvement tends to be focused on, we have a clinical outcome that we don't like and we want to try to fix it. So it is often very local. It really prioritizes in a very good way the expertise of frontline clinicians and trying to use what they witness day in and day out in care delivery to fix a problem. The focus is on fixing a problem in that local context. So implementation science differs in a few ways. One, it is meant to be theory-based and driven by decades of behavior change research. So as opposed to just saying, what do we around the table think is going to work, the idea is to pull from theory to help determine what changes might be effective in this given context. A second important difference about implementation science is that one of the goals is generalizable knowledge. So as Dr. Hisrchhorn mentioned, that's the science part of it, is that we're not just fixing a problem in our local setting, we're trying to create knowledge that lets us fix problems in maternity centers across the country based on what we're learning in this local setting. And I think that's what's so what I love about this area of work is that we have such finite resources, and this is a wonderful way to help use every one of our quality improvement projects to create generalizable knowledge, so we're all learning together instead of these kind of isolated projects where we don't all have the benefit of learning. I think I guess my related response to your first question that was posed to the panel was, I think we have a lot of work to do to help our field understand what implementation science is. We are kind of decades behind internal medicine and surgery in terms of like health services research broadly, and then kind of more narrowly thinking about implementation science. My experience has been, just sort of challenged getting implementation science work published in women's health journals. I am on a K award right now, and we explicitly, after talking with program officers at both the Agency for Healthcare Research and Quality and NICHD, we intentionally went to AHRQ, and my K is funded through AHRQ because I didn't feel like I could get my K funded through NICHD. And so I think the priorities in our field aren't necessarily oriented around the research questions that we're passionate about. And there is just a general maybe misunderstanding about some of the questions and the value that they might add. So I do think that is one of our biggest challenges, is helping people understand what is it that we do and how might this be able to help? What is the value add here from taking an implementation science approach?
Jennifer, you don't mind, I'm just going to jump in with one of the questions that we had sort of written as a in case of quiet question, but it relates to what you just said, Dr. Moniz, which was, and something that I've had struggled with too. It's how do we sort of raise better appreciation for this kind of work then within the world of more traditional obstetrics, I guess, or traditional maternal health, to the point where they're interested in funding, publishing, publicizing the kind of work that we all know is important.
I might try to just maybe take a crack at it, because I think we were sort of in a similar situation around quality maybe about 20, 25 years ago, when people were like, well, just like get them the services. And I think there was not a recognition of quality. And then maybe 15 years ago or so, it was really, well, how do we make this more patient-centered? So I think we're really getting people to not have this leap of faith that if we tell people, if it gets published in a high impact journal, that it will change behavior. And so I think it's really it's this sort of really interesting balancing of getting the people who you want to consume this information to appreciate the way. And again, for me, it's de-jargonifying what we're doing. I mean, I loved your appreciation of the ERIC thing. Every time I look at it, it's like 72 strategies, and some of them are like a little bit different, and some of them are really different, and I can never quite find the one that I actually want to implement. So how do we actually make this more approachable and get people to understand what it is we're actually talking to them about? And then at the same time also, though, again, remembering this is research, and so bringing in the rigor that is meant to actually design to really bring new knowledge and generalizable knowledge, and that there is really fundamentally there's a role for both of them. And I'm sort of involved right now in the development of a grant that's looking at an intervention for improving breastfeeding. And it is very important for that site to improve their breastfeeding rates. And that, if that's all they're interested in, that's quality improvement, and that's great. And you hope through some kind of community of practice or peer network, they can share. But often they won't understand exactly what happened. Like they'll say, oh, we're going to do these 3 things. I said, yeah, but aren't you also doing like audit and feedback? They go, yeah, but we always do that. I said, no, but that's part of what you're doing. So I think it's really being better to articulate to the consumers why this is important and why it's better to actually bring in to understand why it might work in your setting, but how you need to adapt it to be adopted in other settings. But at the same time, also then embracing the framework and the methodology and understanding the rigor that you need to actually get it funded, and continuing to similarly educate the stakeholders about why this is so important. And if COVID is nothing else, it is the biggest contextual factor I know I personally have ever seen in my life. And I went through as an HIV provider when there was no drugs going to like drugs available, and that was pretty big. And so it has shaken a lot of the very carefully designed methodologies that people have done. We just had to move from a step wedge to a difference in difference in a multi-district intervention. And that's okay, because we're sort of hanging on to the frameworks and the methodology and using something called FRAME, which is a really useful tool to help you document what changes you're actually making and why you're making them. So I think it's really understanding how you talk about this to your different stakeholders and still remaining rigorous enough, as I call it, perfectly rigorous enough, that this still remains to be researched. Otherwise, it's quality improvement, which is a very good thing. But it is, if it's just for local, it's just for change, and nobody's going to learn anything beyond what's happening at the facility or at the unit, great for the unit, but that's not research.
Just one point. It also helps us, this implementation science frameworks helps us to understand what we are really doing. Because we might say, okay, we are doing audit or we are doing PDSR, but what is actually happening in the facility is a huge amount more. So whether it's actually understanding which issues to work, which indicators, yeah, or the pre-work, or the training, what is sometimes done, the leadership components which are actually needed to implement quality improvement in a good way. So all these frameworks, if you really apply them and if you really look at them, help us to understand our own interventions. Yeah, and that makes it then also applicable, because it makes it then much clearer why implement the same intervention works in one setting and not the other, because often it's truncated.
I want to follow up on that and just say, I think to answer the broader question that started this conversation, I think the proof will be in the pudding, and the more we can do good work and get it published, the easier it becomes to get people on board. And there's so many interesting questions right now that are fascinating, and we have an immense opportunity to address. So I was doing my primary area of work, my K award is looking at implementation of evidence-based practices for peripartum contraceptive care. And in doing this work, we'd done a multiple case study and, analyzing that. And there were these really interesting findings that were emerging about implementation champions. And it wasn't in our original plan to look at that, but we looked at that. And there were also, I became really curious about costs for implementation. I was seeing all of this variation around the effort and resources that were allocated to this project across settings, and trying to understand, is it just the complexity of the setting that what is it that's driving this variation in costs? And so we did a little mixed methods analysis where we collected some cost data, did some qualitative work to try to understand the drivers of that variation. And again, it was not an original part of the grant we had proposed, but just this fascinating question that emerged that was like so important from this pragmatic perspective, to get this information to decision makers in our field. And so I really have so much just hope that as over the next 5 to 10 years, as everybody on this call is doing good work and getting it published, that people will kind of come along, because they'll see the benefit that this work helps us do our jobs more efficiently, more effectively, maybe have a little more fun because we understand the why behind some of the results we're seeing. And I think that that is tantalizing to people. When you can show them the why, they want more, they're hungry for more.
So I'll add to that as well. I think I love that idea. As an implementer, I'm really anxious for better research to help kind of elucidate the context components of, like, as you do the research, like, okay, if we're all trying to implement, for example, reducing C-sections or overuse of interventions, the problem is very similarly, or at least the goal is very similar. Then I think teasing out like the context specific aspects could be then like and I think it's way too simplistic to say rural versus urban, because I've worked in urban setting with like a low resource hospital. I was over both of them, and I know there's differences between it's more like size but I think there could be some context specific elements that could be very carefully tracked. And then what were the evidence-based strategies that were used in that implementation effort? And then at least have start to get a catalog of what worked in different settings to be able to really start to have much more description around these implementation efforts. And in addition, the data, it's I have you know, again, like these 500 students every year and 125 graduates, and they're trying to come up with structure, process, and outcome metrics. And there's so little detail in the papers of people who've studied the implementation or have made it clear that this is an evidence-based intervention. Even something as recent, like as important as flu vaccines, right? How many studies are there around effective efforts for implementing a flu vaccine in a clinic with these characteristics, right? Do they have, is it nurse practitioner led? Is it physician led? What were the characteristics of the adopters? Anyway, I just think there's so much research that would then help inform implementers, but often the research that gets done doesn't have that implementer in mind. And so I think really making, like really thinking what would be some things that an implementer could pull out of this research. So I did reorganize, and I'll put it in the chat, like the ERIC, because 72 is impossible for an implementer to just like go through and try to pick from those 72. So what I did is I put it into categories of what I call the ABCDEs of implementation. So accountability, buy-in, collaboration, communication, data, education, and mainly, and structure changes. Mainly because I had all of these students who were picking education as their only strategy, right? Like they had no concept of all the they just weren't thinking about those other types of strategies, and then using implementation science findings to know, like, you need buy-in, how do you get buy-in, you know, like, anyway. So I just thought you just got my juices going when you said that, Michelle. And I was like, yeah, that's right. We need more practical approach. So thanks.
Love it in your ABCDE.
Yeah,
I want to see that.
Well, that's what the Regis panel's working off of. Actually, is we're going to then publish that, and we'll hopefully get that published. It will have taken Eric. It will also take some of my own work. And then we're also coming up with the principles of how you will evaluate a strategy, and they need to be like, And some of these strategies are not, there's not a lot of evidence behind them. So being clear, like what, but at least they are strategies that we have seen in the literature, but they just haven't necessarily all been well tested. But yeah, well, if you email me, I'll put my email in the chat. I'm happy to share it. It's a handout I use for my students. I created it just out of like desperation for like, we need something more practical, much more, that people can wrap their head around that are trying to put together these QI projects, for example, right? So.
I'd love to just, there's been a very interesting discussion in the chat as well about the concept of the mechanisms, which I really do agree is sort of one of the underlying kind of secrets of like, why are you doing audit and feedback? Why are you doing training? So there's if you're going to do it, how are you going to do it? Which is the detail of, the whole thing about, you need to name it and who's going to be doing it. And so that really almost it's almost like your protocol. But also it's almost like mini hypotheses. I think that training is going to work because of these particular things. And I think it is a really, really important thing about how to map and whether if your strategy didn't work, is it because you didn't do it the way it was that it needed to be done, or was your actually underlying hypothesis about the mechanism incorrect? So I think it's a really important and I think a little bit coming late to the attention, but I agree, Tara Lewis and other people have done some really great work in that. The other thing which I do want to keep on bringing up is this idea about voice. And a lot of my work now is in other countries, so not countries that are my own. But in the US also, with a lot of the disparities work, that we often don't have the right voices and we don't often give credit to the right voices. And so when we sort of talk about sort of stakeholder engagement and community participatory research, that we really need to take that very seriously and do that with as much attention as we do in terms of our power calculations and other ways. And that's yet one more area that I think we need to continue to educate funders. And so AHRQ and PCORI tend to be more friendly to that, but I've been told by funders, like, can't you just get started? Like, why are you spending all this time doing this? So really making sure that as we start to work on the very much need to work around equity, around disparities and all the other things which have been shown in maternal and neonatal health for way too long, that we bring in some of that same sort of critical eye of strategies that work to really get that voice involved in there. And the idea about what evidence is behind some of these strategies, I completely agree. There's Alex Rowe did one that was on all the different quality improvement strategies, and it's one of the most depressing reads you'll ever actually do in your life. But the fact is that a lot of these haven't actually been shown to be effective. And so we have to sort of figure out how we're defining effective for these strategies. You can't RCT all of them. And perhaps that's another area where we need to go in terms of the research.
But add to that question, I think we've been talking about disparities a lot, and it's one of the things that we really wanted to bring up. How do you all feel about how implementation science can specifically improve health disparities, and are there strategies community champions, things like that? What do you think are the key strategies that can sort of help reduce these disparities when you're implementing in maternal health?
Are we going forward or backward in the alphabet?
Let's do backward this time.
Okay.
Okay, so I think I'm up. I guess I don't know that I have a comprehensive answer, but I will offer a few observations. One, we have to meet this amazing moment in time that we are in. Implementation science aside, I think we as a field are, for the first time in my career, are having a meaningful conversation about racial and ethnic disparities, structural racism, other structural disparities set up in the fabric of American policies and culture. And I think we have to meet that moment in time with our work. We are called to do that and to right the injustices we see in the world in front of us, and to use our research as a tool to catalyze that process. So that is an exciting opportunity for us. I think ACOG, other maternity care organizations are engaged in this conversation in a meaningful way. And that is really a gift for all of us, that I think this momentum that we can use to move the work forward. From the standpoint of implementation science more specifically, I think there are two tools at our fingertips that may be very useful. One is the focus of implementation science on key stakeholders, on designing strategies with end users in mind. And so involving patients as we design our implementation work is so critical. In this multiple case study I mentioned, we looked at 11 hospitals across the country that were changing their peripartum contraceptive care processes. Not a single one involved patients in the design of their new care delivery. And the rationale behind changing care delivery processes was to better meet patients' needs. And we weren't even asking patients to be at the table with us. So I think it sounds so obvious, right? But yet we missed that. We weren't doing it. So I think that's important. And then secondly, making sure that we are measuring the right outcomes. And this is so difficult in maternal and child health because we have so few outcomes. And in fact, in the handful of nationally endorsed quality measures of maternal health, contraception is one of the only ones. And how strange, right? That is one of our only markers of the quality of maternal health care in this country. So I know that space well, and can certainly comment on the fact that the outcomes that are easiest to measure in the case of contraception, contraceptive method use is easily objectively measurable in claims data and other data sources. And yet it in no way approximates this multifaceted concept of the quality of contraceptive care. And so I think as we start thinking about the patient experience of maternity care, and which underlies a lot of the disparities and inequities in outcomes, right? Disparity just means difference. Inequity, I think, is a better word because it implies that it is our policies and processes that are driving these differences in outcomes, right? They are not innate. They have been created by us, and we need to dismantle them. I think it will be crucial to collect patient-reported outcomes data as part of quality improvement efforts, as part of our implementation efforts. So making sure that as we define what counts as efficacy and effectiveness, that we are not neglecting to include our patients' voices, both in designing those measures and as we collect measures of outcomes along the way, centering the needs of our patients, centering their voice, even though it's going to be harder and take resources to collect that data. I think that's really, really central to being able to address the inequities that we currently see in our field.
I think I am next. Sorry, I'm having a little trouble with my alphabet here. Yeah, no, I think, again, it's really the idea about understanding more about where the gaps are and why we need to address them, and really expanding out our viewpoint beyond, sort of what we come in with a priori. But again, hearing from all the different stakeholders, taking a systems view, and understanding, again, it's, I come from traditional quality training, improvement training, which, focused mostly on the individual and a little bit on the systems. And the idea is if you keep on training people, maybe they'll finally learn to do what's right, which we know isn't, looking at all the different barriers we've used, so really that's, I think, a really important thing. And then finding out whether or not you've actually chosen the right strategy and how to implement it well. And planning a priori to see whether or not, you can either try to do this by actually directly addressing the community that has not been well served. You can try to do something which is, looking at improvement overall, but you need to then keep a very close eye on whether you're actually making your inequities better or worse. And ideally, having people catch up as opposed to being further left behind. So I think those are very important. I think for me, the one plea I would say is that, again, looking back to the early days of HIV, there was an enormous amount of very, very elegant research that helped understand what was the problem and the factors associated with the problem. And I worry sometimes when I see a little bit of the formative research getting stuck there. And I think one of the calls to action for us is to make sure that when we talk about implementation research, we don't forget about the implementation. And so that we are able to really, collaboratively design the right measures, the right interventions, and test them and see whether they're right, adapt them, and continue moving forward. Because if 2 years from now we have an even more exquisite understanding of the underlying causes of inequity and we have done nothing about it, I would think that that would be a failure for what implementation research and implementation science more broadly can do for maternal health.
I would like to bring in the perspective of the health workers. So in the present crisis of COVID, we see under how difficult situations they actually work. And they are the ones who are very often actually not properly asked what kind of new technology, what kind of new things they really need to better implement for their patients. So their perspective is so crucially important. All this new technology, all the things which are actually running around, if the health providers do not perceive this as something which is really useful, first of all, they will not use it. And second, we also risk very much of losing too many health workers, particularly in this crisis, although we need them so much more than at other times of our lives. Here in Sweden, I hear now with all the emphasis at the moment on critical care, that the health providers actually would like to run away from the healthcare, because they feel they cannot do actually what they would like to do. They cannot be friendly anymore. They cannot really care for the people because they have all this the things between them and the patients, and they cannot their ethics nobody cares of. They cannot ask for a critically ill patient the parents or the children anymore to say goodbye and all this kind of really horrible things. So the health provider's perspective is critically important, and that we might need to bring in even in the implementation science thinking even more.
So I will add to all of these great comments that I also think that there needs to be implementation research around how to shift paradigms. In the maternal health care, one of the biggest paradigms is that more will bring about better outcomes, and we have a primarily healthy population coming in to have a baby, with overuse being like one of the major drivers, overuse of cesareans in particular, overuse of interventions overall, as being major drivers of morbidity rates that have increased nearly 200% in just a very, very short time. Overuse of inductions, which are leading to higher rates of uteroneoteny, the leading cause of hemorrhages. And so we have this crisis, but a lot of what's driving the crisis, and in a lot of the narrative around the crisis, is that somehow if we do more interventions, that's going to address the crisis adequately, rather than really right-sizing the interventions we do have, meaning in this case clinical interventions. So I think one of the so I would love to have implementation research around paradigm shifting, and there's probably some out there, but I think in particular around OBGYNs. I mean, we have seen we have natural experiments where VBACs were being promoted. There was one paper by ACOG and it's shifted, and all of a sudden all these VBACs went away. So I think, you know, I think there's some interesting case studies and an interesting way to think about maternal child health is from an implementation research perspective. If one big idea, and I think it's really and I can't remember who said it, it was one of the panels I was on, but I think it would, and it gets to points that other panelists are making, is that we need more real-time data. This is outrageous that we are, think about trying to run the COVID pandemic if we didn't have weekly data points. Think about trying to address a maternal health crisis with 4-year-old data. We cannot do it. So we should have monthly preliminary data released, and it should be by race, ethnicity. As messy as that is, that would be, we do that with employment data. Why can't we do that with maternal health data? And it's some of our key, it's such an important part of our communities, is how our mothers and children are taken care of. So we should be releasing that data in preliminary form, and then we would have that data to work with, and then we could use it from both an implementation perspective as well as implementation research perspective. So and I think, you know, that would help us really hone in on a lot of the structures, the processes, and these outcomes that are very different. So because I think there's these myths that people have that the reason for these disparities are related to the individuals, and those myths are perpetuated by these ideologic misperceptions and so trying to really get rid of the myths around that, you know, like we have to dismantle textbooks and risk adjustment models and all kinds of things which are completely possible. And so we need multiple ways in which we hold ourselves accountable. So if I change one thing, it would be those data structures to hold us accountable and help us see as a nation. So all of us working implementers, implementation researchers, could all be getting much more real-time data to help drive our efforts and create our research and to create our implementation efforts, and know which pockets are being left behind, have those geo-mapped out. And all of that is, it will, at the beginning of any project, the data will be less refined and less accurate than it will be as you go forward. So just be comfortable with some of that discomfort. So if I could wave my wand, that's what I would do. So.
Thank you so much. So we might have time for one or two more questions. I'd like to ask a question that builds off some of the comments in the chat related to, you know, the difference between QI and implementation science, but thinking about, you know, how, you know, we're implementation research, we're trying to close that gap between evidence and practice. How do we make sure that we're not setting up a parallel gap between implementation research evidence and quality improvement practice? And so thinking about that, you know, what are some concrete steps that we as implementation researchers can take to make sure that the generalizable knowledge that we're developing is actually being able to be put back into use for quality improvement, either through educational settings like Debra's work, or also outside of that and more broadly through a lot of the initiatives that are going on for improving maternal health outcomes. And,
I don't know if we're going in order. So do you want us in order or just first up?
Whatever's easiest for you. Should we do order again? Okay, so if we do order again, then we'll go in forwards order. So that would be Deb first.
I was going to let everybody else go. Why don't we go? I'll skip. Well, then I'll be last again. No. So I just have spoke a lot all of a sudden. So let somebody else go, and then I'll get back to it.
I'm happy to go first. I think this is part of the, I think there's sort of two things that we can do. One of which, again, is getting back to the stakeholder, because if people are knowledgeable and involved, I think that it's going to resonate more. And then you figure out who is the best communicator for this. So the first is, you know, sort of learning from some of the countries I've worked in, which, you know, so the head of the DG of Director General in Ghana said, basically, if you come to me with a completed study, I have no interest in it. But if you involve me and the people that you're supposed to be working with from the beginning, you will make sure that it is actually more applicable, and it is ultimately what we call actionable knowledge. There's generalizable knowledge, but if it's not actionable, it's not transferable. How do you actually take it from one setting in, you know, say in, I don't know, Chicago, and how do you then move that to rural Iowa? You know, that's the kind of thing, it makes it more actionable and generalizable. So I think the first is how we actually design and do the studies. But then the second is the D of the D&I, is the dissemination. And I think that's an area where we don't tend to focus as much about, you know, we're talking about strategies that have evidence behind it. You know, the dissemination strategies is an area that I think we need a lot more work in, is how do we actually help translate this into something that people actually need to know. How do you do this? There's a triangle that we often think about, which is evidence, policy, and practice. And often dissemination and implementation research focuses on the evidence into practice. And if we ignore the policy and getting policy into practice as well. I think that's one of the challenges. So we have to think about who are the different audiences that we need to be talking to, that we need to be disseminating to. So is it the frontline provider? Very important. Is it their manager? Is it the person who writes policies? Is it the politician who actually is going to vote on whether or not you're going to get funding to do this or changing the incentives? And then very importantly, is it the community and the person who's actually going to be involved in whatever the changes that we actually need to have. So I think thinking in the same way that we think about the strategies for getting from evidence into implementation, we need to start thinking about, once we have that, how do we actually do a similar kind of approach about what the most effective ways are of communicating and actionable, and what are the tools that actually need to be developed to actually get people to both understand, to want to uptake, and to be able to uptake the evidence that we're producing.
It's not also a little bit about co-design? If you think of quality improvement, we actually need to know from the people, so what is actually really needed in a context and what could work. So this, if you put it in an implementation sign context, it will be much more structured than actually just having a one group conference and, okay, let us think through what's needed. And then you can go for the next step also in a co-design, from a co-design thinking of actually, so will it work? Can we evaluate whether it works? And then you have the next loop of actually adaptations so that it really fits to the context, fits to the people, and meets the need of the those who actually need the services. So I like to think implementation science, co-design, and quality improvement much more in continuous loops. And then it's also, I mean, this is not a typical project plan, what you can implement for 2 years or 3 years. This ideally should actually have a long-term perspective. And there we have a problem with all the project, research project design thinking, which is actually designed to have a start and an end.
I want to elevate two concepts that have kind of already come out in this discussion. I think that, you know, we have to tailor our message for the person we are talking with, and that is so essential in any change program. And so as we think about, you know, the person in front of us, is it a nurse? Is it a pharmacist? Is it billing staff in our hospital? Is it a resident physician? Is it, you know, a midwife? What motivates them? And how can we talk about this initiative in a way that is meaningful and gets folks on board and aligns our shared values? I think that we all need to become incredibly adept persuasive communicators. That is such a huge part of any change effort. And we have to, the people leading change initiatives have to be so skilled at that. And it's something that is not necessarily baked into our training. And so I think we have to figure out how to teach people that skill set. Secondly, one of my mottos is never trust a provider. Find a medical assistant, a nurse, somebody else on the team that is actually going to get, you know, the process stuff done. And I think aligned with that, I have come to see in the contraceptive world, it's not enough to tell people this is an evidence-based practice. It is proven. We have to do this for our patients. They just won't necessarily get on board. And so our team is really thinking a lot about policy change, capital P policy change. So if this becomes a quality measure that's in the HEDIS data set, guess what? Now everybody's incentivized to do this. And so I think we have to be thinking about which levers, when we pull this lever or this lever, where are we going to get the most bang for our buck? And we often need to be pulling 5 or 6 levers all at one time. And so thinking about that in a prospective, strategic way, I think that's how we're going to see the most exponential impact for the efforts we put into change.
So I appreciate everybody's comment, and I agree with all of them. I will elevate a couple of things that I'm doing, just in case you want to work with me on any of it. I would love to get some collaboration on that. So I am in the process at both the school as well as in my the Institute for Quality Improvement, which I founded, trying to increase the utilization of implementation science research among implementers, making it more practical. I would love to have some suggestions, ideas, and help in that regard, as well as QI methods and tools. I actually run day-long workshop on quality improvement and do other kinds of things around that. With disparities, I have what I call the Speak Up Against Racism Action Pathway, which includes both QI methods and tools. It's a mnemonic as well as an acronym. So anyway, I have evaluation needs and also ways to think, like, because I'm making what I call them actually Speak Up Champions, and I would love to have, I just started our evaluation team. If anyone wants to consider be added to that evaluation work around this is an dismantling racism. It's a training program action pathway that includes both implicit, explicit bias education. But I would love to have more help in that regard. And then I think just overall, I love the statement around the partnerships. I found collaboration, like you've done, like Rebecca and Jennifer, like, my goodness, this is changing things, right? Because then we all met each other, and the power of collaboration. When I started the California Maternal Quality Care Collaborative, we got together and we had no idea that we could reduce maternal deaths by 50% in 5 years. We just didn't, but it's amazing what a group of people can do. And the research is clear, like, that's where things change, is really like-minded people coming together with motivation to make it different. And I think you know, the time is very much there for us to do that. And it's such a pleasure to be with all of you today. And thank you for this opportunity and making this possible, Rebecca and Jennifer and all the other panelists. So really appreciate it.
Well, we're thrilled to have everyone here as well, and especially to all of our panelists. Thank you for such important thoughts about where this field has come from and what are the things that we need to do now to really have an impact. I think you give us a lot of ideas to think about. So we're just bumping up against the time that we had for on the agenda for the panel discussion. So thanking all of you, we really appreciate having you here and all of the thoughts that you shared. I think we won't have enough time for one more full question, so we should probably move into the networking session next, which will be breakout rooms that are going to be automatically assigned. We have a few questions that we'd like you to talk about in the breakout rooms. So just to get everybody started to get to know each other, we wanted to ask you all to introduce yourselves to each other, share where you're working, what type of work you're doing related to implementation, research, and maternal health. And then also, as an icebreaker, come up with one thing that your group has in common that is not related to work or implementation, research, or maternal health. And then we have a Google Sheet in order to be able to share the information that's coming out of these groups across groups. We have a little Google form where you can put in information for the next 3 questions that we wanted to ask you to think about in the small groups, which are, first, ways that we can support each other and possible collaborations to help advance this work, either research collaborations or organizing together to promote implementation research. Then also to think about, for question number 4, what resources do you think are most needed to help advance implementation research for maternal health? And lastly, thinking about how we can keep this group going and continue connecting with each other. What conferences you regularly attend that could be venues for future interest group meetings, whether, we'll have a poll towards the end of the meeting about what you would work best for all of you and what you'd be most interested in. But thinking about what might be some of the sites for places where we could meet again. And there is, in the agenda that you received, there is a link to that Google Sheet. So once you get into the breakout rooms, if you could assign or one person volunteer in your group to just type in some notes from your group's discussion into that Google Sheet. And with that background, we'll go into breakout groups now. It'll be automatically assigned, and then we'll plan on coming back in 25 minutes to the larger group. It'll automatically bring everyone back at 1:45. So thank you again so much to our panelists for this really wonderful discussion. And then we hope that you have another great discussion in the breakout groups, and they should be happening now. So now we just have a little bit of wrap up after the great discussions that we had from the panel and also from the discussion groups. And we wanted to talk to you about, some of the options and opportunities we might have for moving this work forward, helping to support implementation research in maternal health. So I'm going to be talking about a process for setting implementation research priorities, and then also, what we can do with as a group, all of us, to stay connected in the future. So the first thing to think about is, as Rebecca presented earlier, there's been a lot of growth in publications in maternal health that include implementation research keywords, which is the search that we did in PubMed. So if you look at the past 10 years, it's been growing by about 20% every year. And if that growth were to continue, that would put us at almost 4,000 publications by 2030. So just in 10 years, with 20% growth every year, that would be a lot of research that would be being produced. And one thing we'd like to do as a community is to think about how can we be strategic in our efforts for implementation research to really advance maternal health and improve outcomes? And also, how can we advocate for this work? There was discussion in the panel about challenges with clinical communities seeing the value in this work, funders seeing the value in this work. How can we really advocate to support this work with funders, to get it published in journals, and help other stakeholders see the benefit of it as we're producing so much research? So one of the things that we can do is follow the lead of some other organizations. You can have the next slide. To really set formal priorities in maternal health, which can help us to advocate for this research. As you can see from some of the examples that are included on this slide, there's already been work in setting health outcomes priorities for maternal health, both in the US domestically, as well as in international organizations for global health through efforts like the Healthy People Goals and the Sustainable Development Goals. The US Department of Health and Human Services recently came out with a maternal health plan that sets some priority goals as well. And there have been a few research priority setting exercises that have been done both in global maternal health and the United States. There was a recent report from NICHD with maternal health research priorities that was published in AJOG. Some of the global health research priorities do touch on implementation research questions, but we would really need to bridge the evidence to practice gap in global health. But the priorities for maternal health research, particularly in the United States, have left out implementation research, and what are the implementation research questions that we need to ask to get evidence-based practices into routine care more quickly and more equitably. So we think that particularly in the United States, we need some implementation research priorities to help guide how we address the maternal health crisis that we have. So we set about thinking about how we would do this as a community, as a group. And we looked at the research priority setting approaches that have been used. This figure is from a systematic review of health research priority setting exercises. And you can see there are a couple predominant methods. There's the CHINRI method and the Delphi method. CHINRI actually stands for the Child Health Nutrition Research Institute, but they're a group that was funded by WHO and World Bank to develop some research priority setting approaches. It's actually kind of a more rigorous Delphi approach. And it's become the approach that's been most commonly used for research priority setting in health. It's been formally used by the WHO for quite a number of initiatives, especially around child health. And so looking at these different approaches, we thought that this would be a really good fit for an exercise to set research priorities for implementation research in maternal health, especially with some adaptations. because the implementation research questions are very context specific, we thought that we should really focus on doing these within certain contexts and settings. So because there are some priorities that have been set for global health, we're really focusing with the exercise that we'd like to do going forward on the US context, because we don't yet have implementation research priorities for the US context. So what we've planned is to do a priority setting exercise following the Chinri approach starting early next year. It's a adapted Delphi approach, so it involves 2 rounds. First, we identify experts in maternal health in the United States through literature search approach, and then some additional snowball sampling from the experts that are identified. And then the first data collection round solicits priority practices and research questions. So it'll ask about, what are the evidence-based practices that we need more evidence about scaling them up and getting them into routine care with high quality and with equitable delivery. And then also, what are the research questions more generally about implementation in maternity care settings in the US? So it'll first solicit brainstorming ideas about what are the potential areas of focus. Then we'll do some analysis on those and look at the common themes that came out, and have a second round of data collection where we'll go back to the same experts that were identified through the literature search and through the snowball sampling, and ask for you to rank the practices in terms of several criteria, such as what will be the most high impact for improving outcomes, what will be the most feasible to actually implement, what will make the biggest difference on implementation. So we're planning to go through these data collection processes starting January next year. So the first round survey will be in January 2021, and then the second one, after a little bit of analysis, would be in March 2021. And then we'd like to present those results back to the group. And we welcome any input that you have about this priority setting exercise, and hope that you'll participate as well. And we think that this will be something that can be really beneficial for everyone to advocate for their work too. Once we have some published research priorities, that puts a little bit of extra ability to cite and ability to advocate for this work. Then the other future thing we'd like to get input on is future meetings for IS4MH. So we've thought about a couple of ideas for how we can continue this group. For presenting here. So continuing with what was the original concept for this meeting before it went remote, which was a 2-hour in-person adjunct to the D&I meeting. Another is a in-person 1-day pre-conference to D&I, where we might be able to have enough time and space to do research presentations. That would probably also involve some registration fees in order to have space to meet. We can also have more small adjunct meetings around other conferences, such as the Society for Maternal and Fetal Medicine, some global health conferences possibly. And then we could also continue the community online with more frequent online events, maybe a community of practice webinars, which have really helped to promote certain types of research and implementation science. Like I participate in one for configurational comparative methods. That's been really great for building a nice community around that methodology and implementation science. So that's another option. So we want to get your feedback on these. So we have a Zoom poll that I'm going to launch now. They'll ask you to rate your level of interest for each of those 4 options. And then among the 4, if you had to pick one, which would you prioritize? And then that poll will be able to give everyone the results back from all of you right away. So I'm going to go ahead and launch the poll now. So we'll just take 2 minutes to answer those questions, and I'll end the poll once it looks like everyone's had a chance to answer. Okay, so we have 97% response. So I'm going to go ahead and end the poll and share the results. So that should have shown up for you. So in terms of the first question, how likely would folks be to attend an adjunct meeting at D&I? It looks like we have about 50% that think that that would be possible for them and they'd be very likely to attend. Adjunct meetings at other scientific meetings, also look like a possibility, especially in terms of the somewhat likely rating. Oh, sorry, that was the pre-conference. The second question is a pre-conference to DNI with research presentations. So that has a little bit less interest. Similar interest for the adjunct session at other meetings, and then a lot of interest in the regular online events. And then that seems to be the preference, is the frequent online events. So thank you so much for this feedback. This is really great to think about how we might continue convening this group and bringing everyone together to collaborate. Okay, so we've reached the end of the program today. We really hope that this has been beneficial for you. We want to thank you for coming. It was an incredible turnout. We had over 100 people register, and we had quite a number of you actually come today. At some point, I think we got over 50 coming. So thank you so much for participating and being here and joining the group. We sent out the registration list to everyone at the end of the agenda, so please use that to continue connecting with people and collaborating. Then please be on the lookout also for the invitation to participate in the priority setting exercise. We think that that's something that can help advance all of our work. And finally, please, again, get in touch if you have other ideas about how we can continue to keep this interest group going and supporting each other's work. So on behalf of Rebecca and myself, thank you everyone so much, especially to our panelists, but to all of the participants. We really appreciated having you here. Thank you, everybody.
Thank you.
And have a great rest of your day.